No.
Thank you,
All right,
Amanda.
it's 1:02. Amanda just told us we should get started.
All right.
Okay, so good afternoon, everyone. Thank you so much for joining us in our brown bag of the Department of Global Health and Population. And today is our really great pleasure to have Mary Bassett. And I think we tried to bring Mary like 3 times and always something happens. So today's the day, and I'm glad she's here. She's the director of the FXB Center of Health and Human Rights. She's the FXB Professor of the Practice of Health and Human Rights. And she has just been appointed the New York State Health Commissioner. So she has a full plate. But Mary today is gonna talk to us about something that has kept her really busy since last year. And she's going to talk about structural racism and why should we care about this in global health. Mary, thank you so much for joining us, and the Zoom is all yours.
Thanks very much, and it's really a pleasure. This is a pretty expansive title of my talk, and I'm going to focus mainly on what I think about when I think about structural racism. But of course, I wanted also to think about why this should matter to people outside of the United States. And the struggle of people of African descent in the United States for equal rights, which is tied to having better health, has long grabbed the attention of the world. The Mexican Olympics, when 2 athletes stood on the victor stand with their fists raised, remains an iconic image. But the notion of structural racism is really not that recent, although it seems recent to us. Now we hear it talked about a lot. But W.E.B. Du Bois, who was really one of the seminal intellectual giants of the 20th century in the United States, way back in 1900, talked about how the context of lives of people of African descent in Philadelphia, which was what accounted for their poor health, their housing, their access to health care, their access to decent diets. And similarly, today, in 2020, the reason that we are now all talking about structural racism has less to do with an advance in our knowledge about the impact of racial hierarchies on health outcomes than the context in which we lived in the year 2020. And of course, key among those was the murder of George Floyd on May 25th in 2020, which sparked international outrage, not just across the United States, but from Auckland, New Zealand, to Rio de Janeiro, to Lagos, Nigeria, to Johannesburg, all over Western Europe. People turned out on the streets. And this wasn't just because it was so horrifying to watch a man plead for his life, bystanders plead for his life while a police officer held a knee on his neck. It wasn't just the horror of that video clip, which many of us have seen. It was the fact that the racial hierarchy that permitted this to happen, permitted Derek Chauvin, who's been convicted of murder, to believe he could do this with impunity, resonated with people's lives all over the world. In London, in France, people understood that there was a racial hierarchy. And Wikipedia has a map that shows the extent of the public demonstrations that took place in 2020. And those dots are all places where there were more than 100 people who turned out for a demonstration. You could see it was all over the United States, all over Western Europe, but that, I don't know, I think you can see my arrow, that's New Zealand, all over New Zealand, also in Africa and Latin America, in Japan, and so on. So this was really amounted to a reckoning with racism that we haven't seen since, for me, in 50 years. And it also was related to the fact that people saw this as relevant to their own lives, where they went out on the streets, not only police violence, but the violence of everyday life that meant marginalized people could expect to live less long lives. And then accompanying this was the COVID pandemic. And I'm just showing this slide. It's work that I did with Nancy Krieger and Jarvis Chen here at the School of Public Health that showed that really early on, this was in the first half of 2020, the first time that we had the data available to look by race and age at COVID mortality. And at that time, Blacks had 3.5 times the risk of dying. But when you broke it out by age groups, you can see that there were hugely elevated risks of death comparatively. Even though most deaths were occurring in older people, there was a hugely increased risk of death. And this was related not to anybody having any particular defense to this virus. This was a new virus, but to the distribution of exposure, which reflected the racial stratification of who went to work, who lived in overcrowded housing, who worked in crowded workplaces, which weren't able to offer or didn't choose to offer protections to workers. So this is why racism in the United States becomes an issue of global concern, because it brings to the fore the notion that when we have marginalized populations on the basis of who people are and what they look like, we end up with that reflected on people's health and in shorter and sicker lives. It's true in the United States, it's true in the United Kingdom, it's true in South Africa. All of these are countries which have a racial hierarchy. And they're also countries that share a colonial past, right? The United States began as a settler colony for European colonists. South Africa similarly was a settler colony. And many of the people in the United Kingdom who experience excess COVID deaths or deaths from many causes are people who are immigrants from the former colonial holdings of the British Empire. So for me, it still amounts to about half of my working life that I spent in the small country of Zimbabwe. This gives me a chance to show pictures of myself when I was younger, but straight out of training. After I finished my fellowship at the University of Washington, I took a job as a junior lecturer at the University of Zimbabwe. And that's a picture of me at a feedback survey for community groups. And then years later, when we were beginning the process of trying to make antiretroviral drugs available. Rhodesia, which is what Zimbabwe was called before it became independent in 1980, like South Africa and like the United States, was a country with a formal, legally defined racial hierarchy. Rhodesia had an apartheid-like system, just as South Africa did, and just as the United States did, although we don't usually talk about it in that way. There were definitions of race on the books in the United States, held mainly at the level of the state, not by the federal government. The US had something which some of you may have heard of and some of you not, called the one drop rule, which was that if you had a Black person in your family tree, going back 3 or sometimes 4 generations, you would be considered Black. The United States is unusual compared to other racially stratified societies and not having a formal recognition of a mixed race group. And so you would be called Black. And these were mostly before the Civil War. These were all rules defined before the Civil War, but they stayed on the books. In the 1990s, there was a woman in Louisiana who said, I look white, I am white, but I'm classified as Black because of this one drop rule. And she went to court about it and had to fight it in the courts at that time. And South Africa had probably a more widely recognized system. I just quoted this language just to give you a sense. I mean, this one drop rule meant that if you had a Black great-great-grandparent and everybody else in your family tree was white, you would be classified as Black. And during the slavery period would be subject to continued enslavement. In South Africa, they had this definition, which is really awkward. I'll leave it to each of you to try and read it on my slide. But they had a whole bureaucracy devoted to classifying people by race, and you could apply to be reclassified if you felt that you had been incorrectly classified. And this rule wasn't repealed until 1992, around the time that Nelson Mandela was released from prison. So racial classification is a whole area of conversation in itself. This is just to give you an idea that these are not, it seems so natural to us in the United States to classify people by race, but these were often changing rules. They changed for the Latino population, they changed for the Asian population, and they changed for the Black population. Now, when you talk about the experience of being colonized, there are, in my mind, and this is having lived in Zimbabwe for nearly 20 years, really analogous features of African enslavement and the colonial experience. Countries were colonized because other people came there who set up a way of life that enabled them to extract wealth from the environment they were in and from the people who they found there. Similarly, the project of using slave labor was not about, treating people badly. It was about getting people to work and to create wealth. The slave economy was critical to the emergence of the United States as a wealthy country, something that our history books don't always make clear. And of course, in both cases, the colonial domination of peoples of color in Africa and Asia and in Latin America was justified by white supremacy. So that this belief and the variation in human value was sort of cloaked in the notion of a civilizing mission, but in fact was rationalized by the notion that one race was superior to others and motivated by the fact that this was enormously profitable. So that is really the main thrust of my argument about why people who have experienced colonization find the experience of US racism to echo with their own experience, that this wasn't a matter of a bunch of mean people, that this was a structure that was grounded in economies. And this, I don't have an equivalent for colonization, but probably someone could make it. But this is just to remind those of us who are in the United States how little time we've spent in this period here. Some people mark it with this 1954, that's when schools became desegregated. Others in the mid-60s, when the Voting Rights Act and the Civil Rights Act gave Black Americans for the first time universal access to the vote. But you can see that most of the arc of US history not only was dominated by nearly 250 years of enslavement, but had really a very short period in which there were full legal rights. And as we all know, and as COVID displayed and the death of George Floyd displayed, these rights haven't always translated into actual rights. Legal rights haven't always translated into actual rights. So now I'm going to talk a little bit about what we mean by structural racism and how it relates to health inequities. So I think of structural racism as a platform in which other forms of racism, how a person who is discriminated against feels about themselves, how interpersonal relations of people who have different racial classifications occur, and the way in which both implicit and explicit bias is manifest, and also the fact that institutions have rules that don't depend on individual preferences or prejudices. And these in turn modify the social determinants of health, by which we mean things like what you eat, where you live, where you get to go to school, how far you get to go to school, what kind of job you can get, the wages you make. And all of these, we know, relate to health inequities. So in this sense, structural racism is really antecedent to what we call the social determinants of health. Now, I was just on a panel with Slim Abdul Karim, who's a leading AIDS researcher in South Africa, and he was talking about how he grew up thinking that he could never be as good as a white person in South Africa. He's of Asian descent. And that really is what we are talking about when we talk about internalized racism. This is a photograph of an iconic experiment run by Kenneth and Marie Clark, and it was cited in the effort to desegregate schools, in which Black children were asked to pick a doll that they liked. Did they like this doll or this doll? And the vast majority of Black children showed a preference for the white doll. A high school student in New York repeated this experiment in the 1990s and still found that Black children preferred white dolls to Black dolls. So that's internalized racism. Most of the time when we're talking about racism amongst ourselves, until this past year, I would say we are talking about interpersonal racism. This is the way in which people behave towards individuals. This is the person who's not, who's impolite to you when you go into a store, or these are based on personal prejudices. But it's probably not the main form of racism that we should be talking about. And then come institutional and structural racism. This is a photograph of a little girl who was escorted by marshals into a New Orleans school, and New Orleans rioted for, I think, for 3 or 4 days. Over this little girl going into a classroom in a formerly white-only school. And this was after Brown versus the Board of Education. And these schools were segregated by design. It didn't take a white parent to have to say, I want my child to go to school with only white children. The school system was segregated, and typically it was government that made the decisions that these schools would be segregated. So institutional racism occurs at a level above individual prejudice. And it is not simply the sum of individual prejudices. It functions independently of personal likes and dislikes. And structural racism goes even further than that. And I'm going to just read out the definition that we gave to structural racism, and it's closely allied to the notion of systemic racism, that it involves interconnected institutions whose linkages are historically rooted, culturally reinforced, and refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distributions of resources, which together affect the risk of adverse health outcomes. Somebody told me this means that racism is everywhere. And actually, I would agree with that. They feel it's so expansive that it's not useful. But I don't agree with that. The main point of it is that it requires power, often the power of government, not only private institutions, that it has historical roots, and that it is embedded in our culture and is not simply a problem of fixing individuals. It runs deeper than that. But we can figure out how it works. Obviously, people often think that racism is simply a marker of the impact of economic injustice and poverty, but it works to the disadvantage of the Black middle class, for example, even when they don't have economic disadvantage. It works through environmental exposures inside and outside of the homes, and occupational exposures. It works in the ways that products are marketed, and the targeting, almost racial profiling of health harming foods, tobacco, alcohol, and so on. So although it is expansive, it is understandable. I expect everybody knows about the miasma theory, when there were disease-forming substances just sort of in the air, a cloud. But I don't believe that we should see racism as something that is too expansive to be understood. And if I think I have a few more minutes, and I'll try and talk a little, for people who are not native English speakers, if there are any. I'm probably talking like a New Yorker right now. Let me slow down a little bit and give you this example of what's called redlining. This is a program that it was established now nearly a century ago. It was really motivated in part to try and pull the United States out of the Depression of 1929. It was a mortgage program in which there were federally guaranteed mortgages. And the government asked something called the Homeowners Loan Corporation to create maps of creditworthiness by neighborhood. And they did that. And they put red lines around neighborhoods that they considered not creditworthy. And that's where the phrase red line came from. And it so happened that disproportionately redline communities were communities in which many of the residents were African American. So as a result, this pathway to home ownership, which is one of the most important sources of intergenerational wealth transfer, was not available to African Americans. And it also made African Americans who wanted homes vulnerable to predatory lending practices. So this is the reason it's an example of structural racism, is that it took the government that allowed redlining in its mortgage program. It took the banks that implemented it, whether that loan officer liked you or not, thought you were worthy of a loan or not. If your neighborhood was redlined, you didn't get a loan. It involved private developers who came up with these special covenants that you couldn't sell your house to a person of color, for example, to protect real estate values. It also fed into the culture that if a Black person moved into a neighborhood, that home values would plummet, that Black people made bad neighbors, and homeowners organized to keep them out. So this whole process of redlining contributed to the current racial gap in the United States, which is huge, and the racial gap in wealth. The racial gap in income is like two to one. In wealth, meaning your assets minus your debts, it's 10 to 1. In fact, many African Americans have zero wealth or negative wealth, meaning that they have debt and no wealth. And we know that wealth is very important to your health. It's a resource that you have to help protect your well-being. And another example is unequal access to medical care. There's a whole legacy in the United States and that extended to what I saw in Zimbabwe and formerly Rhodesia, in which people believed that people of African descent had different bodies and got different diseases than people who were European. And there were these strange diseases designed, like drapetomania. This was the disease that caused you to try and run away from being a slave. but we're still seeing these things now. I was taught that Blacks have different lung volumes than whites, that kidney function should be measured differently, partly because Blacks are more muscular naturally than whites. And I was taught these things as a medical student, which was not that long ago. And there still are beliefs that Black people, even children, don't experience pain in the same way as white people. A lot of this would fall in the category of interpersonal racism, the holding of prejudice beliefs about people and the belief in the biological importance of race. But there also are other studies showing that hospitals that serve Black communities are less resourced, have fewer specialists, fewer important pieces of medical equipment, so that a Black serving hospital simply has inequality structure in its very structure, and who takes care of patients and what resources they have to look after them, independent also of individual beliefs. And the Institute of Medicine published a really iconic study. It's now nearly 20 years old. It focuses almost entirely on interpersonal racism and on the implicit and explicit racist beliefs of clinicians. I'm hopeful that they'll decide that they also want to look at the way in which the construct of structural racism has a bearing on unequal treatment. But it still remains the most important single piece of work on the inequality in access to high quality medical care. They talked about how doctors just made all kinds of clinical judgments based on their preconceived notions that were influenced by the racial classification of a person. I thought I would end with what I think, I hope, is equally important for people who work in other countries where entire nations have been marginalized and subject to unequal treatment. In a suggestion made by Ibram Kendi, who's now quite famous for his book titled How to Be an Anti-Racist, pictured here. But he came to the health department in New York when I was the commissioner there. And he said, this is how he decides whether or not you should worry about an idea being a racist idea. Ask yourself, are they saying that the problem is the people rather than the context in which they live? And if the problem is said to lie with the people, whether it's their genes or their culture or their belief systems, you should interrogate that as a racist idea. So let me stop there. That's about half an hour. I hope that we have, so it means we have plenty of time for conversation and discussion. And thank you all. And I think should I just stop sharing the screen?
Yeah, maybe so.
Yeah. All right.
Thanks, Mary.
I hope I didn't rush through too quickly.
No, this was terrific. It's amazing because you were describing this. I mean, as you know, I'm from Brazil, and I can see different parallels. It's a different story, but many, many different parallels. And let's not forget, Brazil is the only country named after a tree because that was the very first good that they were removing from.
Is that right?
Yes.
Well,
yes.
I looked it up yesterday evening because I was remembering that you're Brazilian, or I don't know whether you get to have two passports or not, but you're from there. And the U.S. Ended African enslavement in 1865, but Brazil didn't come till 1883, I believe. So you were the last slave republic in the modern era. And
Portugal was the last country to stop the slave trade in Africa. So, you know, and Portugal was the colonizers. Anyway, I'm sorry. So I'm going to start with one question, and we have two questions already, and I want to basically tell everybody, please put your questions in the Q&A. And I don't know, Amanda can answer if we can let people speak up their question. But let me start with one, Mary, you mentioned the redlining, and you mentioned all the different institutions involved on this. We have the government, the banks, the private developers, the country. So can we do the opposite of redlining? Also involving the institutions, but now doing good instead of doing bad. Do we have room for that? And what is stopping us from doing it?
Well, it's money, basically. There's a great book for those of you who are interested in the impact of redlining called The Color of Law, in which he makes the case that fundamentally redlining was a government project. It was permitted and enabled by government policy. And therefore, government has a particular responsibility to rectify it. And this is where the whole notion of reparations comes. But even saying, let's go forward, redlining was made illegal, by the way. But we know that we still have very segregated neighborhoods. Nancy Krieger has done some work on this and shown that historically redlined communities have numbers of adverse health outcomes, even accounting for the present levels of deprivation in these communities. So the historical legacy continues to have an impact in ways that are unmeasured, except for the fact that these areas were historically redlined. So one idea is to say we have to overinvest now in these communities and offset the historical impact of the practice of redlining. Now, why isn't that done? Well, mainly, in my view, that it's because there's a very strong belief that the problem is with the people who live in these communities. They don't look after their houses. They have too many children. They don't maintain their parks. That they make bad choices and have, either through ignorance or through some form of stubbornness, so that it's not a government responsibility to fix this now. Or the responsibility of anyone to fix it now, and that's what the problem is. That it's a resource draw on municipal budgets or on the corporate bottom line, and there's a very strong belief that people end up where they are because of their own innate abilities. So that the reason that people of African descent and other people of color are disadvantaged is because they have various inferior capacity.
Yeah, and as you know, David Williams has all this work showing that, you don't need much investment, but you improve things in neighborhoods and you can see the outcomes, the improvement in health outcomes. And we had this discussion and I said, well, people are willing to pay billions of dollars to spend minutes in space. What the heck is happening with the world? And we're not putting the money where it should be. Yeah. And I'll never forget his answer. He said, I think the world needs more empathy. But
I saw something pop up in the chat, so I didn't see who asked it, that, people don't realize that the newly freed population was literally freed with nothing, sometimes not even clothes on their back. And that the initial efforts to allocate land that had been appropriated from the Confederates, who after all had been defied the rule of law and gone to war. The US Civil War remains the most brutal military experience that the US has ever had. Nonetheless, they were able to get their stuff back, and except for their people. And the newly freed formerly enslaved were left to do the best they could, which often meant they went back into very oppressive relationships, sharecropping, chain gangs, vagrancy laws.
Okay, so Jackie wants to ask a question, and then we'll take some questions that people are putting in the Q&A. So Jackie, do you want to unmute yourself and ask your question?
Marcia, thank you, Mary. That was a really wonderful talk. I've heard you talk on these topics before, but each time I really learned so much. So thank you. I wanted to ask, you started off, I came a little bit late, so I'm not sure if I missed right the room, but you started off with George Floyd and with the conviction of Derek Chauvin. And that's a kind of one lens, which is state criminality. And I wonder whether that lens could be used more broadly. I was just talking to some Palestinian colleagues, and one of them, who is going to do a panel with us in a few weeks, was saying how she thinks that it's no longer appropriate really to talk about trauma. It's really state criminality that is driving so much of the violence. And I wonder, you know, of course, it's not, I don't not an American lawyer, but I don't think it's criminal to discriminate. It's certainly illegal to discriminate, but so much of what you've described is illegal behavior by the government. It's illegal misallocation of resources, illegal, kind of just in terms of constitutional obligation not to discriminate. So is there a role for using that kind of lens more? Do you think it's helpful, or do you think it's unhelpful?
I thanks for that comment, Jackie, and it's been a pleasure talking with you about these issues over the past couple of years. But I think that there has been, you know, we all need to learn more history, actually. I started out by talking about how the United States in some ways can be viewed as a successful settler colony. The indigenous people survive, but reduced by 90% in population and relegated to land holdings that were that meant that most of their land had been appropriated by the European settlers. And similarly, the whole colonial project was similarly an act of expropriation, and this was always contested. It was always violent. And the willingness to reduce the issue of violence to simply one of interpersonal violence and not recognize the fact of state violence. You know, for Black men in the United States, death resulting from a police encounter is in the top 10 causes of death for young Black men. So I think it's a really important idea to talk about the public health threat of state-sanctioned violence. Absolutely. Yes. And it's not only a U.S., you know, you've talked about Palestine. We can talk about, you know, the former colonies. Sorry if I thought I turned off my computer. But you know, this is a phenomenon of colonization. It's not achieved peacefully. It's a violent process.
So, Mary, I'm going to raise a question by James Weathers. If racism is about power, and we know police and law enforcement and other state-based actors and agents serve to protect that power and preserve the status quo, why don't we see more support for defunding, abolishing police and instituting more community-based public health approaches?
Well, that's a pretty long question. I'm looking for it in the chat to see if I can find it.
It's the third one.
The third one?
James Weathers.
James Weather. James is the one who showed the. James, are you there, James? I mean, I think that these structural problems require structural solutions, in my view. So that doesn't mean that programs aren't important. Programs can be very helpful, but they don't achieve the rebalancing of power. But I missed the question about what to do with the police. The third question.
Oh, I put on an answer now. You can just move to the other tab.
I'm sorry, I'm just not catching James. I mean, there's been a whole conversation about what to do about police, and I don't think it's a settled question. Where's James Weather?
James, do you want to speak?
Yeah, why don't you unmute yourself? Sorry. These are wonderful sort of ways of meeting, except when they don't work.
Go ahead, James.
James.
Yeah, I sort of had two questions that was like a follow-up to the first one. First one was wondering why structural racism, historical and ongoing, is still controversial in the US and not just accepted as fact. Germany isn't perfect, but there seems to at least be a shared acceptance of history and people accepting facts about what the Nazis did. Following up to that, likewise, if racism is about power, we know police and law enforcement and other state-based actors serve to protect that power and preserve the status quo. Why don't we see more support for defunding or abolishing police?
Okay, that's a really good question, both parts of it. And as many people may be aware, there's really a pushback. Lindsey Graham is going to be coming to this faculty pretty soon. He is on the record as saying that systemic racism or structural racism doesn't exist. And the proof of it is that we've had a Black president, and now we have a Black and Indian vice president. And these are sort of true unrelated remarks. An individual doesn't fix a structural or systemic problem that explains why we have, the phenomenon of huge racial disparities and incarceration that begins, with who's under surveillance and carrying on through with sentencing. It's an example of structural racism as well. So this is a political issue. And we're seeing it play out politically. It is not it is not an argument that's taking place in the realm of fact. It's taking place in the realm of ideology, and there's a real commitment to white supremacy in this country, and it's one that is unacknowledged, but continues to affect our national discourse. I think on the question of policing, and the phrase "defund the police" can cover a whole range of things. It's not quite the same as saying we need to abolish the police. I think, well, at least speaking personally, I think that there is a role for policing, but I think it's fair to ask the question. Why should 3 police officers, or was it 4, show up for a counterfeit $20 bill? Armed individuals show up for a counterfeit, $20 bill. So, or why are they doing traffic stops? I mean, why do we have armed individuals doing traffic stops, which is what most police, spend a lot of their time doing: noise complaints, traffic stops. Defund the police can also mean let's talk about when we need an armed response to a public complaint, and when should it be somebody who doesn't have a gun, because when people have guns, they will use them. And that is a political issue. I assume that policing in the United States has its origins in the slave patrols. They were the first armed non-military force in the United States, and their job was to find runaways and return them. And so the kind of racial tinging of civil safety notions has real historical roots in the United States.
Okay, so now there's a question from Maya Shashua, and the question is, going into your new role, do you have a vision for how you will link many of these concepts of racial and economic justice, structure and history with a historical lens to health programs in the state and in the coming months or years?
Well, that's really, I very much hope so. I can tell you what I did when I was a New York City Health Commissioner is that I called on the agency to take a racial equity lens, a health equity lens to all of its work. And it was a two-pronged process. One was looking at all of our programming and seeing whether or not we were looking at it from the point of view of equity. And New York City, at least, is a very segregated city. Boston is pretty segregated, but not nearly as segregated as New York. And then there was the internal process that the department had to start asking itself, why do we look the way we do? Why do we ask the questions we ask? And a whole investment in educating ourselves about how racial inequities in health persist. I'm hopeful. Part of that is having data. I know that this starts to sound very wonky, but the US racial ethnic data is still really not very good. So part of it's improving the data, increasing data transparency. We had to rely on a British newspaper, The Guardian, to do an inventory of police-involved killings. That was how it came to public view that there was such an inequity in who was dying related to police encounters. We should have those types of data. Public health agencies should have those data because our responsibility in public health agencies is to keep track of the patterns of death and disease. So data is one thing, programming is another, and working to change the culture of our organizations and institutions is another thing. So I'll bring all that to the New York State Health Department.
Yeah, if you can't measure, you can fix, and it's it's part of a discussion that it happened in the school before, which is if you really want to bring a human rights perspective to public health, you need to collect data with all those levels of details. Yeah. You need to know who are the people, where are the people, and then you can identify the most vulnerable and therefore act upon. If you don't have that, I mean, for how many months we didn't even have any breakdown of COVID deaths by race and ethnicity.
By race.
We didn't have it.
For 6 months into the epidemic.
Exactly. So there is a question that is connected to the previous one. So I'm going to ask that one. It's the last one put in here. So the COVID-19 pandemic exposed the loss of access to acute care from 20 years of hospital closings and downsizing in some New York communities and neighborhoods where Black, Latinx, and other people of color live. How can we reform state and federal oversight of a market-driven hospital system to better ensure that health equity is a priority and that proposed transactions would actually serve communities' needs? That's an easy question, right?
Yeah, another really easy one. New York City is unusual in having quite a robust public hospital system, but it's in trouble. It's always in the red. And so are other safety net hospitals, while other private nonprofit hospitals have substantial budget surpluses, which if they were for profit would be called profits. That is a complex question that has to do with the distorting impact of profit on medical care. And, I personally would like to see a universal government-run system, but of ensuring care, of insurance. But we can still do a lot better with the public health insurance schemes that we have. The New York State Health Department oversees Medicaid for the state of New York. So stay tuned. We'll look and see what can be done. There's something like 7 million New Yorkers who receive Medicaid. Out of a state population of 21 million. It gives you an idea of how many poor people there are. And that's a lot of government money that should be possible to try and leverage into ensuring high quality care.
I'm sure you saw this, Mary, but there was this phenomenal video that was on the New York Times, I think, over the weekend about the Lincoln Hospital in the Bronx.
Yes, I was a young person then. It was did you watch the video?
I watched the video.
I remember that. Yeah.
Okay, so I learned about it. I didn't know about
Yeah.
this. But one thing caught my attention, well, many things caught my attention, but one of them is that one of the things they were asking for was, of course, a better hospital and some kind of healthcare, but they were asking for home visiting, which is the basic of primary care, community-based primary care, where you have community agents, and that was never accomplished, never.
No.
And again, as I read those things, I always, forgive me about that, but I always make a parallel with Brazil, and in Brazil we do have that. We have one of the largest community-based primary care with home visits, and that was completely halted during the pandemic. But so was there any attempt, and that's my complete ignorance in terms of history in the US, but was there ever any attempts of actually accomplishing this? Home visits, so you can target the most vulnerable.
Exactly. Well, the answer to your question is no. There's a real crisis in primary care. It just doesn't, it's not financially stable. It's, the kind of cost centers in healthcare are procedures, and it makes more sense for a hospital to invest in having a heart transplant unit than in having high quality primary care. The only area that I know of where home visiting has reached some, sort of level of accomplishment is in visiting to pregnant women and following up with their babies. And in New York City, there is a home visiting program targeted at communities, most of which are formerly redlined communities, which, are the poor, largely Black and Latino communities where there's an effort to visit pregnant women and follow up with their babies afterwards. But, this is some of the ways in which the global experience really, poor countries' experience can inform wealthy countries' experience. We often talk about the use of technology like cell phones and so on, but also methods of delivering care. Home visiting was a mainstay of primary care, the village health worker, and these strategies work. The question is just always who's going to pay for them.
So there are a few questions.
Oh, we should tell people what this movie was about. It was about a group in the South Bronx that the Young Lords were an organization of mostly young Puerto Rican militants who took over Lincoln Hospital. And they, said they've been trying to talk to the administration and it just wasn't working. So they went and they decided that they'd just take over the management of the hospital, and they did it. And they did achieve some changes in how that hospital was run. Sorry, it's available.
It's on the New York Times website. I'll try to get the link and put here. But another thing that they say at the very end is that particular neighborhood had some of the worst outcomes during the COVID pandemic. Exactly the same place.
That's right.
So Mary, there's several questions here around, decolonizing global health and the support that the US gives to global health and all of this. So I'll just collapse all of this in one question, which is we have several of our students here and students across the school, and a lot of people are doing global health or are working abroad or in the US. So in this topic of decolonizing, so what is your 2 cents advice for people that are starting out, who will be the future leaders, will be the people driving the agenda, driving the changes in the future? What is your advice for them on changing the status quo, and if possible, contributing to mitigate the consequences accumulated over this dark past we have?
Wow, I've gotten, I often feel when I have these kind of conversations that I'm supposed to have the answers and I don't have them, even though I've worked in public health for 35 years. What I would say is, having worked in Zimbabwe for nearly 20 years, is having humility and showing respect for the people who have made their, whose lives are in the countries that you may just be visiting, is really important. And one of the things that we learned in the New York City Health Department, and I think is true everywhere, is that you have to have the engagement and support of people who you're seeking to serve. We're seeing that with the whole area of vaccine acceptance in the United States, for example. So I would say that to show humility, to have respect for the knowledge that is there, to not come in thinking that you are the savior. That is almost certainly not true. And if it is true, it just reflects the ways in which communities have been deprived, bad policies, not bad people. So I would urge you, though, it's as an American who's had the privilege of working with some of the best people I could ever hope to work with during my years in Zimbabwe, it's really a good idea also to go to countries that are different than your own, and to learn what it means to work with limited resources, and the importance of listening to people. So these all sound like platitudes to me as I say them, but I think that the fact that the U.S. is a wealthy country hasn't delivered the level of health that we deserve as a country. So we should be really humble in talking to people in other countries as though we have all the answers. We haven't.
And no, we don't. And I think that's a great way to not end, I'm not going to call this end, but stop this conversation for now, because the conversation continues. But, we have faculty and students from all over, and listening from each other and learning from each other's experience is absolutely critical. Yeah. And that's why going to the field, learning from the people that are going through the problems is the way to go. And we as a School of Public Health need to do that, need to have that eye. I think Richard Cash is here, and the two of us keep like our broken record saying that I don't think anybody in this school should get a degree if you haven't been to the field and have exercised listening and problem solving, because that's the essence of public health. Mary, I cannot thank you enough for spending this wonderful time with us, although the topic is brutal, but we learned a lot. We always do. And this is, we wish you all the well in New York. Thank you. And we're going to keep following up and asking you to come and tell us about all the great things you're doing. And best of luck with the new task. Thanks so much, Mary. And thanks everybody for joining and for sending your questions. Appreciate it. Bye.
Bye.